Hello and welcome everyone. Today we'll be discussing about how to master the brain in critical conditions. The challenges in acute brain injury management are high mortality and morbidity despite advances. Brain depends on stable oxygen and glucose levels. The ICU strategies, that is neuromonitoring, drug therapy, prognosis and nutrition, all needs to be optimal to get a good present outcome. Coming first to the basic neurophysiology and pathophysiology. So we all know the brain structure, it is protected by the bones. It has neurons and the inflammatory glial cells. Now, regarding the metabolism, the energy demand is primarily met by glucose and oxygen. It doesn't have any storage, so it requires constant blood supply to stay alive. Without a proper blood supply and continuous flow of energy, some part of the cells of the brain can die. So in injury, there is an immune response because of the structural components, and there is also energy imbalance because the food is not reaching the cells as it should, because the demand is high and the supply is restricted. So the concept is of a core and a penumbra. The core is the directly damaged area of the brain where the cells die immediately. They are unsalvageable. Penumbra is the surrounding area with cells that are weakened but not yet dead. Now, the goal of treatment is to save this penumbra by restoring the oxygen, nutrient, and blood supply to this area before any permanent damage can occur. In ischemic stroke, thrombolysis aims to salvage this penumbra before irreversible damage. So, the long-term molecular changes in acute brain injury are the brain injury triggers long-lasting changes in the molecular pathways. Microglia plays a dual role, help in repair and neuroprotection, can cause inflammation and secondary damage is overactivated. The therapeutic window is larger than previously thought. Recovery can continue for months and even years post-injury. Emerging therapies focus on modulating long-term immune and metabolic responses. The aging and the gender factor. The impact of aging is that older patients are at high risk of acute brain injury due to their cardiovascular risk factor, that is hypertension, atherosclerosis, increased susceptibility to stroke, higher fall risk leading to traumatic brain injury. The use of anticoagulation or antiplatelet increases the severity of the hemorrhagic brain injuries. Pre-existing conditions like frailty, dementia make the recovery more difficult. And weakened immune response and slower healing reduces resilience of the brain injuries. In the gender factor, sex-based difference in acute brain injury, women have a higher risk of subarachnoid hemorrhage at all ages. Elderly women have a higher risk of traumatic brain injury than men. The challenges is that women are underrepresented in clinical trials, making the data less reliable. Hormonal and physiological difference might influence injury response and recovery. Treatment decisions may be unintentionally influenced by gender-based biases. In the future consideration, no current gender-specific treatment recommendations are there, but future research may focus on specific group of patients where the women are more susceptible. So how to evaluate a neurocritical patient? So first we need to check the consciousness, that we can do by the Glasgow Coma Scale or the 4 score. We check the pupillary reaction, the brainstem reflexes, respiratory pattern, and the motor responses. All these should be completed in the initial part. Then you can go on to a structured neurological examination. The role of neuroimaging is important. Some brain injuries may not be obvious in the neurological examination. CT and MRI are critical for identifying such lesions. Complete workup in unexplained coma include history taking, lab tests, brain imaging, pretty standard, and the pupillary assessment is important. The traditional methods, that is pen light examination, is subjective and unreliable. Automated papillometry is more accurate and reproducible, and it matters because pupillary reactivity combined with motor response is better than GCS alone for predicting outcomes. Pupillometry is now a standard in many ICUs due to its precision in brain function assessment. Special consideration that we need to do in the ICU are factor affecting the neurological assessment. The medications like sedatives, opioids, neuromuscular blockade should be taken into account. Delirium, the metabolic changes, the infections, they can also affect my brain condition. Elderly patients, the metabolism of the drug is delayed, they have organ dysfunction, which again can go on to affect the neurological function. In ICU care strategy, always consider underlying metabolic or drug related causes when evaluating neurological status. The diagnostic and therapeutic challenge that we face in unknown origin coma is that the coma is a medical emergency and it can result from various conditions like structural brain lesion, that is a stroke, hemorrhage, or a trauma, diffuse neurological dysfunction like metabolic disorders, infections. Rarely, psychiatric conditions can also precipitate like catatonia, psychogenic unresponsiveness. So how do we approach is initial stabilization, assess and manage the airway, the ABC, then take a proper history and the neurological examination, conduct the first line test like the sugar levels and sodium levels, and do the basic imaging. Then you can do an advanced imaging and entire endocrine workup if required. Regarding advanced investigations, you can do CT angio, which checks for the basilar artery occlusion, MRI brain, which will detect ischemic strokes, demyelination, and subtle brain injuries, and endocrine workup can also be done. In the ICU monitoring and prognosis, use GCS or force score regularly to track the neurological recovery. Outcome depends on underlying cause and timely intervention. Delays in diagnosis worsens the prognosis, so early aggressive evaluation is critical. Neuromonitoring is vital. The role of neuromonitoring is that it is the patients with severe brain baseline deficit and sedation make bedside examination of very unreliable. Neuromonitoring helps by preventing secondary brain injury in neurocritical patients, preventing primary brain injury in general ICU populations. So how we do it? There are some non-invasive methods like pupillometry, which we have done in the beginning. We continue to do it in the ICU, ultrasonography to check the optic nerve sheath diameter, EEG, NIRS, non-invasive ICP monitors. Then you also have invasive neuromonitoring, that ICP monitoring, brain tissue perfusion, jugular venous oxygen saturation, and cerebral microdialysis. Apart from that, there are more advanced neuromonitoring concepts like cerebral perfusion pressure and autoregulation, multimodal monitoring, and use of AI. Regarding neuroimaging, it also has a critical role. CT scan is for quick assessment where you can do even more deeper tests like angio and perfusion imaging. MRI is more detailed scan, it will give better outcomes. So functional MRI and challenges in transport are important when considering ICU patients. Regarding biomarkers, these all biomarkers can be used, and with the use of this biomarker, you can use the neuroimaging as a complement, using both to make a better prognosis. Dynamic changes, like sometimes some changes they pseudo normalize. You may find that lesion is gone, but the patient has not improved. So that must be kept in mind. White matter loss over time must be kept in mind. So how do we feed this injured brain? The brain's energy demand, as we say, are very high. The brain consumes 25% of the total body glucose. Glucose is its primary energy source in the normal condition. During stress, the glucose level rises to maintain this brain energy. However, excess glucose worsens outcome in acute brain injury patients. The blood glucose control is important. Hyperglycemia can damage the brain even without the primary injury. Hypoglycemia will also damage the brain, so that also must be kept in mind. So glucose control is critical. Tight glucose control has shown mixed outcomes. Early parenteral nutrition worsens hyperglycemia and has been mostly abandoned. Recent RCT showed that lower glucose levels slightly improve morbidity. Now, alternative energy substrates like lactate and ketones are potential alternatives to keep on going with the brain metabolism even after injury. Hypertonic lactate enhances cerebral perfusion, increases glucose availability. Ketones, that is ketogenic diet, promote cellular repair and reduce inflammation. Successfully used in chronic epilepsy and refractory seizures. However, large trials in brain injured patients are actually lacking. Regarding the brain organ crosstalk, the multi-organ injury in ABI often damages multi-organs simultaneously, especially in trauma cases. The example is trauma patients with TBI have chest injury in 35%, spine injury in 18%, and abdominal injury in 17% of the cases. These injuries can worsen the brain outcome due to hypoxemia, hypertension, and systemic inflammation. Apart from this, the effect on the brain can also affect the lungs, like impaired consciousness can lead to aspiration, pneumonia, and ARDS. It can cause cardiac stress, resulting in sympathetic storm and cardiomyopathy, endocrine imbalance by HP axis activation, and other hormonal imbalances, disruption of the gut microbiota leading to infection and inflammation. So this is how the ABI affects other organs. So challenges in treating patients with multi-organ dysfunction in ABI is a therapeutic conflict arises when treating multiple organs. For example, say you are increasing the blood pressure to improve the cerebral perfusion. That can go on to worsen the patient's heart failure. Lung protective ventilation, that is high P, permissive hypercapnia, can increase the ICP. So you have to keep a balance. Regarding the future direction in these cases, research is needed to modulate the neuroinflammation to prevent long-term damage, optimize the nutrition strategy, ketones and lactate-based feeding, improve gut microbiota by reducing the systemic inflammation, develop personalized treatment strategies to minimize the organ conflict. Alcohol is an unexpected neuroprotectant, and some observational studies have suggested that moderate alcohol may have a neuroprotective role, reducing inflammation and oxidative stress, dampening the excessive immune response in ABI. However, there are other confounding factors present. Alcohol per se can result in accidents and trauma to the brain. So, overall, no clinical evidence as of now to use alcohol as a neuroprotection. Its harms are still outweighing the benefits that we have seen. Regarding uncertainty in the neuroprognostication, the challenges in predicting ABI is already known to all. Early and accurate neuroprognostication is crucial, but remains highly uncertain. The key issues that we face is over-reliance on early withdrawal of life support may create a self-fulfilling prophecy bias. Many prognostic models lack ICU trajectory data, making long-term prediction unreliable. Prognostic tools have high specificity but poor sensitivity, meaning some patients may recover despite initial grim outlooks. Post cardiac arrest prognostication after cardiac arrest is better defined with poor outcomes, like current guidelines recommending wait at least 72 hours, use at least two concordant tests before withdrawing of the care, avoid personal biases and nihilistic predictions in this patient group. Regarding the need for standardized prognostication methods, bias in communication with families can influence the end of life decision. Future research in this line is blinded outcome assessment to reduce the bias, studying patients not affected by the early withdrawal to improve predictive accuracy. The future in neuroprotection is there are many emerging therapies like stem cell therapy and gene cell therapy, but they have their limitations. They have not yet been fully utilized. Prognostication remains a challenge, as we have seen a lot of biomarkers, but still not into clinical practice. How to utilize them, we don't know. We clearly don't have any proven drug that will improve the neuro part, and also neuroprotection is not really proven. There are still phase 3 trials going on. The trial designs need to improve, better selection of the patient needs to be done, even patient stratification based on biomarkers should also be done. So to conclude, the management of acute brain injury and its prognostication, we need proper neuromonitoring, appropriate imaging, supplemented by biomarkers, support for the multi-organ dysfunction, personalize the care, because there will be a lot of permutation and combination. We have to personalize all this aspect. There cannot be a one guideline that fits all. And future will always be for the regenerative therapies, where we try to build up the neurons, but then they are still in the experimental stages. Thank you for your patience.